All the air travel was totally paralyzed.
Yes, I'm glad I wasn't traveling yesterday, that's for sure.
Banks could not work, hospitals could not work.
Yeah. It was our hospital, we canceled everything that was not emergency. And the financial costs of a whole world being shut down for one day must be astronomical. I'm worried about how many decades of lawsuits are ahead of us for this company that made this mistake.
Mr. Suraj, you have any slides?
Yes, sir. Good evening, sir.
Good evening to you. How are you?
I am good, sir. How about you?
Yeah, good. Just a couple of minutes.
I'll be back in 30 seconds. I'm going to get a glass of water.
Sure, sir. Hi, Amit. How are you?
Fine, sir. How are you?
All good.
It has been this rainy day for long. And then, sir.
The camera was shut down and you said I got a new laptop.
Good evening, sir.
Hi, good evening. Mr. Chandra, how are you?
Good, how are you doing, sir? Planning on talking for about 45 minutes, maybe 15 minutes at the longest, and have questions. Does that work out well for you guys?
Absolutely. Perfect.
It's good to see Dr. Kuter. I've met him in Singapore 10 years ago. He
Yes,
visited
how it's good. Yeah, I do. Yeah, thank you. Nice being there. I was in Bangkok at the ISTH meeting 2 weeks ago, and I realized how warm and humid it is in your part of the world. So Boston has become that way recently.
Hey!
I'll make no political comments tonight about U.S. politics. Okay, I'm going to avoid that topic entirely.
Sure.
Suraj, you can share your screen.
Yes.
So it's starting. Please go.
So, good evening, respected member of medical fraternity. I, Suraj Tiwari from Intas Oncology, welcome you to this novel initiative of Mumbai Hematology Group and Dr. M.B. Agrawal sir to this novel webinar on using pathophysiology to guide current and future treatment for ITP. And we are indebted towards Dr. M.B. Agrawal sir for bringing stalwarts on hematology every weekend for us. So we all know Dr. M.B. Agrawal sir. He is an institution himself and inspiration for all of us. And he has been awarded the Inspiring Hematologist of India and very recently the Guru Dronachar Award by Indian Leukemia Academy. So sir, over to you sir for course of the presentation. Thank you so much, sir.
Thank you, Suraj, for those kind words. Good evening to one and all. Today, our speaker is none other than Dr. David Kutter from Boston. He has done a number of webinars for us during last 4 years. He was physically present in Mumbai last year, and we enjoyed interacting with him. Today, he will be lecturing on using pathophysiology to guide current and future treatments for ITP. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash, Mr. Kalpesh and team from Perfect Square, the Executive Committee of Mumbai Hematology Group, of course, our guest speaker, Dr. David Kutter from Boston, all our discussants who are themselves eminent adult or pediatric hematologists, and you participants for sparing your Saturday evening. Tomorrow morning at 11:30 a.m. Indian Standard Time, we have a webinar on CAR-T therapy in myeloma, the Indian experience. And we have two speakers, Dr. Vikram from CMC Vellore and Dr. Padmaja from Hyderabad. That's 11:30 a.m. tomorrow morning. We have a galaxy of discussions today. Don't have time really to do justice in introducing them to you. So I'll be very brief. We have Lieutenant Colonel Dr. Rao from Bangalore, Dr. Amit Khurana, Surat, Dr. Amita Mahajan, Delhi, Dr. Anand Prakash, Bangalore, Dr. Anil Sharma, Gwalior, Dr. Atish Bakane from Nagpur, Dr. Rahiman from Manipal, Dr. Dagjit Chandra from Faridabad, Dr. Kapil Garg from Jaipur, Dr. Krutika from Chandigarh, Dr. Ajaytha from Coimbatore, Dr. Shrikant from Hyderabad, Dr. Ramzan from Jodhpur, Dr. Chaudhary from Bhopal, Dr. Neeta from Noida, Dr. Priyanka from Varanasi, Dr. Rajat from Kolkata, Dr. Santosh from Patna, Dr. Saroj from Bhubaneswar, Dr. Siddharth from Vellore, Dr. Silki from Noida, Dr. Shirisha Rani from Hyderabad, Dr. Srinivasan from Chandigarh, Dr. Sunil Bhatt from Bangalore, Dr. Sunil Jondale from Raipur, Dr. Khanna from Delhi, Dr. Vandana Bhardwaj from Bangalore, Dr. Vaneet Anand from Ambala, Dr. Virendra Patil from Hyderabad, Dr. Vignesh from Chandigarh, Dr. Vinod from Trichy. And just to complete the formality, may I introduce Dr. David Kutter. He's Professor of Medicine, Harvard Medical School, Director, Clinical Hematology, Mass General Hospital, Boston. He received his undergraduate degree from Harvard College, DPhil in biochemistry from Oxford University, before obtaining his medical degree from Harvard. He divides his time between medical education of fellows and medical students, clinical care of patients with a wide range of hematological disorders, and clinical research. His basic science group was one of the labs that discovered thrombopoietin, and his clinical research group carried out seminal studies using thrombopoietic agents in transfusion medicine and ITP. The recipient of several awards, including the Irving London Teaching Award at Harvard Medical School, the Alfred Krenes Teaching Award at the Mass General Hospital, Douglas Family Foundation Prize for Research 2008-2010 at Mass General Hospital, the Jane Green Memorial Prize for Teaching at the Mass General Hospital, and the 2013 Ernest Butler Award from the American Society of Hematology. And this is just a brief list out of many more. He's given over 500 invited lectures in over 50 countries, and he has served as visiting professor in Beijing, Sydney, Tokyo, London, Durham, New Haven, and Mumbai as well. He has authored or co-authored over 300 articles published in international peer-reviewed journals, including The Lancet, the New England Journal of Medicine, and Blood. Today, he'll be lecturing us on using pathophysiology to guide current and future treatments for ITP. Thank you, and over to sir.
Thank you. Let me make this work. It's good to see everybody again, and I thank you for your kind invitation to speak with you today. I'm going to put this on slide presentation, so I hope everybody can see this.
Yes, sir.
Hear me. Good. Well, again, Dr. Agarwal, congratulations on your recent award. I'm certainly going to join in giving you the applause you deserve for organizing hematology in such an elegant and helpful fashion to all your colleagues. But thank you for inviting me today to talk again. It's always a pleasure to meet with your group. I'm going to talk about some newer areas in ITP, which I haven't had a chance to talk to many groups about in the past. These are my disclosures. I work with many groups that develop new therapies for ITP. And I'm going to focus today, and I'll start with my conclusions, which may allow you to know where I'm going to go. I'm going to start by saying that ITP pathophysiology is complex, and understanding it helps guide new developments and therapies for its treatment. Secondly, ITP is a disorder of reduced platelet production. Corticosteroids and the TPRAs increase platelet production. And there's a new TPRA called heterothrombopeg, which I'll talk about briefly. The ITP is a disorder also of increased platelet destruction, and I'll describe a whole bunch of new therapies, some of which reduce anti-platelet antibody, and there are things like anti-CD30 molecules and inhibitors of the neonatal Fc receptor, and a very interesting group of molecules called IgG proteases, which may have broad application for a lot of different immune processes. I mentioned briefly inhibitors of complement. I'll describe to you some newer things that inhibit phagocytosis, such as modifications of IgG, inhibitors of Syk kinase, and inhibitors of BTK. And I'll present data which is as new as 2 weeks old, presented both at ISTH and EHA by our group and others. So that's my overall goal today, to talk to you tonight about this. And we'll briefly comment upon the epidemiology of ITP as an introduction. ITP is a clinical diagnosis for those who don't see this disease. Platelets are under 100,000, no other clear cause. We like to describe primary versus secondary. About a third of all ITP is due to other disorders, such as autoimmune diseases. And then, as you know, the hematologists are becoming like oncologists and having staging systems. We describe newly diagnosed ITP as the first 3 months, persistent ITP is months over 3 and up to 12, and chronic ITP is over 12 months. These are rather arbitrary distinctions, which I think will be changed in upcoming guidelines. And finally, I will say that most patients don't require bone marrow biopsy for diagnosis, and indeed a bone marrow biopsy is used only to exclude other diagnoses if they're of concern. ITP in the United States is a disease not just of young women and men, shown over here, but increasing a disorder of our aging population. And most of the patients I take care of right now are over 60 years old as having ITP. This is a change in our view of ITP over many years. The third area of introduction is that ITP is more than just a bleeding disorder. This is an old slide, which is not very good, that says if you have ITP and are over 60 years old, there's a slight increased risk of fatal hemorrhages versus younger age groups here, and non-fatal bleeds occur also as you get older in life. But again, bleeding is our major concern with ITP, but as I'll describe momentarily, there are other problems with ITP that we've ignored. The first is that ITP is also a thrombotic disorder. If you look at a group of patients, and I'll tell you, we will be publishing in the next couple of months a data set of 187 million patients, of whom 10,000 have ITP, confirming this data. But basically, if you compare ITP patients here versus those who are age matched without ITP, there's an increased risk of DVT and PE in those with ITP, a much greater risk of myocardial infarction than in those who don't have ITP. Again, this is a thrombotic process, and we can discuss in questions, if you have them, as to why this may be the case. Furthermore, what's interesting is we always worry about in ITP patients bleeding at low platelet counts. And I will simply draw to your attention, this study showed that if you have mild thrombocytopenia, platelets of maybe 75,000, or severe, less than 50,000, the bleeding, the thrombotic risk increased as the platelet count decreased. And you say, well, gee, why is this happening? If we compare ITP to DIC or TTP, these are all disorders of increased platelet turnover. And I think what's happening here is in ITP, those with the most robust disease have increased platelet turnover, and that's probably one of the mechanisms by which thrombosis occurs. So we have bleeding as a problem. We have thrombosis as a problem. We also have quality of life. And this is a rather complicated slide, which has lovely colors in it. But basically, if you compare ITP patients in the green to healthy individuals in the blue, or arthritic patients in the red, physical functions markedly decreased in ITP patients, as is social function, probably because everyone's bruised. So there's a marked effect of ITP in the quality of life. In data that I can't present the data for right now, I'll also say that there's data we will present shortly showing that the length of life is also decreased modestly in patients with ITP. And finally, and this is an important topic to discuss if there's time, cognitive function is impaired in patients with ITP. This is the normalized Z-score. So below -1 is considered significant. There's a whole bunch of different domains of cognitive function which you can identify by testing that are significantly reduced in ITP patients. And these domains of motor function and visual attention are markedly decreased in patients with ITP. And this is independent of the therapy they're on. So it's not just the corticosteroids. And indeed, if you do an analysis of cognitive function, this data was published by us a week ago. 59% of patients have impairment of more than 2 cognitive function tests, which may explain some of the problems that patients have, particularly the ability to work. And this is something we're exploring in greater detail in terms of its mechanism. So those are the things we worry about in ITP. And I've shown you this slide before. This is my view of me. I used to have lots of muscles, but I'm still tall. We make platelets in my bone marrow. They enter my circulation, and they're cleared by a normal process of apoptosis throughout our body. If we develop an anti-platelet antibody, our rate of platelet destruction, primarily in the spleen, increases. And for many decades, it was thought, based upon the work of Harker and Finch back in 1968, it was thought that we increased the rate of platelet production to compensate for this, but that's not really happening. In ITP patients, we have a problem where we have a suppression in part of bone marrow platelet production and the increased rate of platelet destruction. So we have a destructive process and a bone marrow inhibitory process here. All of these, as I'll mention in a moment, are caused by antibodies or lymphocytes impairing these processes. And so the main therapies for ITP currently, and I'm going to only briefly talk about current therapy, the current therapies are things that decrease the rate of platelet destruction or promote the rate of platelet production. And that list is shown here. These are what happens in terms of therapies. Things that increase platelet production are the thrombopoietin receptor agonists. And as I've mentioned to you in prior talks, corticosteroids also, as one of their mechanisms, increases the rate of platelet production. Current therapies that reduce IgG production are things like rituximab, maybe mycophenolate. Things that block the Fc-mediated clearance are corticosteroids, fostamatinib, and IVIG. And finally, you can take out or remove in part the spleen, which is the major site of platelet clearance. But these are the standard approaches to ITP. And just to put it all together in terms of our current thinking of ITP, this is a publication we had a couple of years ago that described current practice. This is the practice at my hospital, but also reflects a lot of the Western practice of ITP. The initial therapy is corticosteroids, rarely IVIG unless you're bleeding to death. Corticosteroids for 8 weeks, by which we wean patients off steroids. And if you're steroid dependent or unresponsive at this point, the next therapy which works is a TPRA. And at this level, probably 85% of patients have a good response. In patients who fail the TPRAs, we can switch to a different TPRA. We can switch to fostamatinib, or we can use rituximab. And by this stage, we'll have treated effectively with adequate platelet counts, probably 85% of patients. Those that are still somewhat unresponsive will add an immunosuppressive drug to either very low doses of prednisone or mycophenolate. And then we get about 5% of patients down here who fail almost all these therapies and are considered the more difficult patients. And I hate to use the word refractory, but that's been commonly used to identify these patients. And these refractory patients are usually put on clinical trials, and then sometimes they're splenectomy. A rare patient says to me, I want this over now, and we'll consider splenectomy, but I rarely do it. They will always get rituximab up front just to prove that they might not have a good response to rituximab. But splenectomy has fallen off to the point that I think I've taken 2 spleens out in the last 35 years in ITP. This is the current algorithm in my hospital for ITP patients. The take-home message is short doses of steroids, next TPRAs, failing that, a different TPRA, rituximab or fostamatinib. If you need a higher platelet count, usually immunosuppressive drugs like mycophenolate will give you another 10 or 20,000 platelet count rises. And if you fail all these therapies, we reassess the need for therapy and usually put these patients on clinical trials. And the reason why I'm emphasizing this is I'm going to talk about clinical trials in ITP in a minute. And this is the group of patients that usually gets put on clinical trials, those that have failed all of these other therapies. So it's a rather select cohort of patients that we're studying these days in ITP. We don't do many studies at this stage here just because there's so many other options for therapy that patients have. So that's my introduction to ITP in terms of current therapies. What I'd like to do is talk to you about the newer approaches to treating ITP, which are in the pipeline and are quite exciting to me for ITP and also other immune disorders. So let's start with mechanism. This is our friend Dr. Harrington, who infused into himself blood from patients with ITP. His platelet count dropped down to low levels and it came back up again. Other volunteers in his lab are here. They became co-authors of his paper, and this showed that there is an immune substance, and we now know that to be antibody in ITP patients. We have done studies in our lab as to the types of antibodies, and I'll simply say that if you look at 260 patients, about half are positive for all 3 antibodies against all 3 major platelet antigens. There are small groups of patients that have only 1B9 antibodies, smaller groups of 2B, 3A, and no patients have 1A, 2A is the only antibody present. So we're measuring that which we can measure. I will simply add that when I present slides like this that say antibodies against platelets are present, I'll also say that 22% are negative. And that may be because there are other antibodies we don't detect that are causing ITP. Based upon the antibody hypothesis for ITP, think of these antibodies as doing 2 things. As we'll talk about, they inhibit megakaryocyte platelet production, and they increase platelet destruction in many ways. They increase Fc gamma-mediated clearance of platelets by macrophages. They may activate complement on platelets, and they may cause platelet desilation and clearance by a different mechanism. We're going to try to discuss these mechanisms next in my discussion here, with a focus on new therapies which are being invented for this disease process. So first point, ITP is a disorder of reduced platelet production. How do we know this? Well, we know this because if you add plasma from ITP patients to megakaryocyte cultures, 12 of 18 cultures shown here inhibit megakaryocyte growth. So that's one bit of data. And there is a lot of other data that comes from other studies that show this is the case. And the model I'd like to leave you with is this. This is a megakaryocyte in the bone marrow. It's being attacked by antibodies. It's probably also being attacked by lymphocytes, particularly NK cells. And the megakaryocyte that you see in a bone marrow of an ITP patient is undergoing programmed cell death and dying. So this leads to the first therapeutic modality. How do you protect a platelet from dying? And the answer is that, we have several things that affect platelet production. I will say that corticosteroids reverse this process. The recombinant human thrombopoietin, primarily in China, and the TPO receptor agonists, of which there are 3, ramipelstim, L-trombopeg, and avatrombopeg, available in North America. And I'll mention the new one, heterotrombopeg. I'll come back at a later discussion in a couple of years to talk about another therapy that has not yet been developed to the extent that it's worth talking about. But these are the available therapies we have to increase platelet production from that megakaryocyte that's being attacked. So What is prednisone doing? And this is a bit of data that illustrates platelet survival data. This is using chromium labeled platelets. This is by Terry Gernsheimer. This was published a long time ago by Terry. Patients with a normal individuals have a normal platelet count. Platelet survival is 10 days, and this is the production rate, 41 units per day of platelets. If you have ITP, your platelet count's reduced. Your platelet survival is shortened, as you'd expect, but in this manuscript, she nicely showed that platelet production was reduced by at least 50%. These patients were then given corticosteroids in the form of prednisone. The platelet count rose, and what's interesting is the rate of platelet survival did not increase, but the rate of platelet production did. So this goes back to another aspect of prednisone. It does many things in ITP, but one of which it increases platelet production. What about the TPRAs, which is the second way to increase platelet production? Well, here's this megakaryocyte being attacked by antibodies and lymphocytes and dying. If you give a TPRA, it binds to the thrombopoietin receptor megakaryocytes, and it makes the megakaryocyte no longer undergo apoptosis. So these megakaryocytes, which there live and now make platelets. And this is the prime mechanism, I think, of how TPRAs work in ITP. And I'll be honest with you, this is the weakest of the facts I'll give you today in terms of how about ITP. This has been poorly studied, and if you have any junior investigators or even senior investigators who want to get distracted, this is a nice area to think about. Are there new agents for TPRA? The answer is yes. There's a new agent which we have briefly discussed in the past called heterothrombopeg. Here's its chemical structure for the chemists in the audience. This is 10 times more potent than L-thrombopeg. We know that because if you look at the stimulation of megakaryocyte growth in a tissue culture, here is L-thrombopeg at 1,000 nanomolar, and at 1/10 that concentration, heterothrombopeg actually makes more megakaryocytes. So this molecule has been nicely tested in many studies. It's now approved in several Asian countries, and I don't know globally what its penetration is going to be, but this is a study from our colleagues in China. They have placebo patients here, patients on low-dose heterothrombopeg here, patients on high-dose heterothrombopeg here, and what they show is the placebo patients don't change in 10 weeks. Those on a higher dose have a rather rapid rise in platelet count by week 2, as is true of all these agents, and the response is well maintained. This molecule has the same side effects as L-thrombopeg, and it may be added to our clinical armamentarium globally for ITP. Certainly it's available in China, and I believe also in Thailand. Now, most of the focus in ITP research, and in terms of new therapies, comes on a different side of the ITP pathophysiology. We talked about ITP being inhibition of megakaryocytes. Let's now talk about the more classic idea of ITP, is that ITP is a disorder of increased platelet destruction. This is a nice cartoon. It shows a macrophage binding to an antibody-coated platelet, and here's a platelet that's already been ingested. So platelets are destroyed in many situations by macrophages in our spleens and maybe also a little bit in our liver. We can model this and use this as a basis to discuss new therapies for ITP. So here's our Fc gamma R3 receptor on a macrophage. Here are some lovely green platelets. And now we're going to propose that an antibody against platelets occurs. So the first thinking about how to treat ITP is, can we make the antibody disappear? And the answer is there are many therapies currently being developed or present that do this. You can take out the spleen, which is the prime site of antibody production. You can give corticosteroids, which reduce antibody production. You can use an anti-CD20 molecule like rituximab, or use IVIG, which also helps clear antibodies. These are things we know decrease anti-platelet antibodies. I'm going to talk for the next 5 or so minutes about new drugs which are available that turn off antibody production and have been shown to have activity in ITP. And I'll start with the anti-CD38 molecules. I'm going to ignore the new anti-CD40 molecules because none of these work. I'll mention that immunoproteasome inhibitors like bortezomib work, but these have not been highly studied. I'll mention B-cell activating factor inhibitors that are under study. I'll focus primarily on the neonatal FC receptor inhibitors, and I'll describe to you a really neat molecule, which is called an IgG protease. So I'm going to talk about anti-CD38, B-cell activating factor, neonatal FC inhibitors, and IgG proteases. So let's talk about CD38. CD38 is a molecule on the surface of many cells. It has a primitive, it's a very primitive molecule. You know, you can find this in sea urchins. It works really well as an enzyme, and it's got many effects. So it is a primitive molecule. It's been used by evolution for many purposes. It's on plasma cells, B cells, and T cells, and NK cells. It has two modalities. One, it's an enzyme that alters calcium influx in many cells, but also it's a receptor for many different immune functions. And basically, if you get rid of CD38 by knocking it out, you have a major immune deficiency in animals. But you know, here is CD38 here as its enzymatic function, and it has a whole bunch of other effects in terms of its interaction with the immune system. So this has been targeted, as you well know, by daratumumab in myeloma cells for those who treat myeloma, and it very nicely kills the myeloma cells. This is a cartoon from a myeloma paper. But there are several molecules that are now being used in immune disorders. And one was published 2 weeks ago in the New England Journal of Medicine from our colleagues in China. It's got a name called CM313. This is an anti-CD38 monoclonal antibody. And what they showed in this very nice paper is that if you give it to patients with ITP, the platelet count rises over 100,000 in a large number of patients within 1 week. So in 1 week, the platelet count rises significantly and is maintained in a target range for the duration of study. The infusions are given for 8 weeks, shown right here. But what's interesting is that if you look in the gray down here, these are the patients who responded and maintained their response. These are the patients who responded, and then the response lapsed over time. And so we have two groups, half about 2/3 of which sustain their response and a third relapse. But this shows efficacy of this molecule in ITP patients. And they went on to say, well, gee, how is this molecule working? And this adds a bit to our discussion of ITP. As you all know, in myeloma, if you give if you give daratumumab to a myeloma patient, you're going to decrease the IgG concentration. And this molecule also decreased IgG concentration to about half normal at day 105. But remember, the platelet counts rose on day 7 without much change in IgG level. What this molecule did do is it made the monocytes disappear almost instantly, and it made the NK cells disappear almost instantly in these patients, which brings the question is, why are these patients responding so fast to this molecule? And it may be because anti-CD38, as is its effect in other cells, it may not just be an antibody concentration. It may be affecting other cellular immunity processes like NK cells, which we actually haven't studied too much in ITP. And this leads to a whole bunch of other thinking about mechanisms of ITP. And I'm not going to talk more about those now because I don't have the answers. But this is a new molecule published 2 weeks ago. On that very same day, our group published data with a similar molecule called megagetizumab, TAC-079. This is another anti-CD38 molecule. And we also showed that in patients who got the higher dose of drug, almost all the patients had a normalization of a platelet count within 2 weeks. And that was maintained for the duration of the study. So this is a drug given for 8 weeks down here, and the effect in the yellow here has been maintained for quite some time. If you look at the response, and this is data we presented in Bangkok a couple days ago, or a couple weeks ago, at the higher dose, 91% of patients had a response at the high dose. A complete remission, platelet counts over 100,000, occurred in 82% of patients. These were amazing responses to a drug, and the mechanism, I think, is still unclear as to what we're doing here. But again, This is the new therapy for anti-CD38, which I think is going to have major promise in ITP. Let's switch gears. This is our friend, the IgG molecule. It's got a part out here that binds the platelet, and here's the Fc receptor region down here. As many of you know, and I think I've talked to many of you about this before, we have a receptor in our body called the human neonatal Fc receptor. It binds IgG, it binds albumin, and it binds it at pH, but doesn't bind it at pH 7. So this is a very interesting molecule. This molecule is responsible for the long half-life of IgG of 21 days and the long half-life of albumin of 20 days. How does this work? Well, here is a endothelial cell. And here's an important point that I think I have not mentioned to many of you before. Every day, our body's chewing up half of our plasma volume in the endothelial cells. You penocytose plasma, the pH drops, IgG binds the neonatal Fc receptor, other non-bound proteins in the green here get degraded, the endosome recycles to the surface, the pH rises, and it releases the IgG, giving it a long half-life. If you have an antibody or a substance that poisons the neonatal receptor, it binds the receptor, you internalize both pathologic antibody against platelets and normal antibodies shown here. All the antibodies get degraded and nothing gets recycled, and this drops your IgG level. One of these molecules is approved in several countries called efgartigimod. This is a Fc part of an antibody. This is very sticky. It binds aggressively to the neonatal receptor, and it doesn't come off at neutral pH. We have studied this and published this last year in Lancet. This is ITP patients who got control therapy. These are patients who got the neonatal inhibitor, efgartigimod, and the IgG levels dropped by about 60% and remain maintained. What happened to the platelet count? Well, this is the change in platelet numbers. The median rise was about 30,000 by week 2, and that was maintained. However, only 22% of patients had a response versus 5% in the placebo group down here. And this, got us a nice publication. The drug worked, but it didn't work in a lot of patients. And unfortunately, and this is the important message right now, not to detract from the work that we did, is that a subsequent study where we gave the same molecule, but subcutaneously, had no effect. It did not raise the platelet count. And we're still trying to study whether this is due to the mechanism or the modality of therapy. So there's a lot of concerns about these molecules in treating ITP. Let's switch gears again. The B cell has got a receptor called the BAFF receptor. There's a BAFF molecule in our circulation. It binds to the receptor and stimulates lymphocyte proliferation. There is a whole treatment process right now in a wide variety of diseases using an inhibitor of the BAFF receptor called VAY736. I hate these names, but it binds the BAFF receptor and inhibits it, so it doesn't activate the B cell. Furthermore, like rituximab does, binding to the BAFF receptor here causes ADC-mediated clearance. So this does two things, that it inhibits B cell function and it reduces B cells. This molecule is being studied in a wide variety of autoimmune conditions, including ITP. There is modest effect in Sjogren's disease, but studies will be maturing in the next 6 months to tell us whether this modality works. That's item 3 for making antibodies disappear. The last thing I'll say, and I think this is the thing I'm most excited about, and I think you ought to think about this in a wide variety of diseases. Bacteria make proteases that degrade IgG. These proteases allow staph pyogenes to be very aggressive in killing people. It secretes a protease called imlifidase, which is a protease. That protease cleaves IgG right about here, and it cleaves off the FAB portion and disconnects it from the FC portion. This is a molecule which has been approved in Europe for clinical use in one situation. If you give it to patients who need a kidney transplant and have very high levels of anti-HLA antibody, You can give the molecule, and about 6 hours later, all IgG disappears, and it disappears for about 3 days. The pathologic antibodies shown here that are giving you troubles with rejection drop to virtually 0 levels, shown in the blue here. And this molecule has been approved in Europe for patients who have high HLA antibodies from kidney transplants. But this molecule has one problem. It's highly immunogenic, and you can use it only once. So back in 2017, this came out, we sort of said, gee, can't do this in ITP or other immune disorders. And here's where something nifty occurs. And that is artificial intelligence. And there's a couple of companies that have done this. They have used AI to take a molecule like this, which has got epitopes that make B cell activation or immunogenic. And you can take a molecule that's highly immunogenic like this protease, play with it, and create a new structure where the molecule is now invisible to the immune system. This is a dramatic, remarkable effect. You're going to hear more about this at ASH in 3 months from now, but this is a new way to invisibilize IgG cleaving enzymes, and these enzymes may revolutionize our therapy of a wide variety of IgG-mediated conditions. You'll hear more about this at ASH. Let's shift gears again. I left you off by saying ITP is a disorder of antibodies against platelets, and if you could make the antibodies disappear, we'd be happy. Well, if we can't do that, what happens next is antibodies bind to platelets and create an antigen-antibody complex. Like many antigen-antibody complexes, you bind complement, and this is then cleared by the C3 B receptors on Kupffer cells. And the question is this true in ITP? This has also been poorly studied. But again, this is data from many decades ago showing that if you have ITP patients, the amount of C3 on the surface of platelets in ITP patients is much higher than normal. C9 is also present. So there is a lot of emerging data that complement is on platelets in ITP. Whether that's a limiting variable or not is unclear. As you all know, the complement field has exploded recently. The drug we developed called sutimlimab I'll describe to you in a second, but there are newer drugs for PNH called iptacopan and danicopan, which are now available in many countries for treating PNH. And to make a long story short, I'm going to talk to you briefly about a classical pathway molecule which inhibits C1. The drug is called sutimlimab. It's approved for cold agglutinin disease. I will simply mention that other molecules that affect the alternative pathway may play a role in clinical situations with other immune disorders, but they have not been well studied. So we've given sutimlimab to ITP patients, and we can take the complement levels here, drop them to 0. When we do that, the platelet count rises in these patients and remains above 100,000. We then stop the drug, the complement activity returns, and the platelet count crashes back to a normal value, back to a low value. And so this is a molecule that we've studied. This drug is not being developed any further in ITP, but other complement factors are, and that data will come out in the next couple of years. Well, if complement is playing a role here, but we can't inhibit it, what happens next? The antigen-antibody complex binds to the Fc gamma R3 receptor, and a whole bunch of things happen on macrophages. You activate the Syk kinase and Bruton kinase, and you internalize the platelet, and they're destroyed. So are there things we can do to inhibit this macrophage? Many things. Corticosteroids do that. Vincristine and vinblastine do that. Obviously, splenectomy takes out a major site of macrophages. IVIG does this, and I'll come back to its mechanism in a second. Then we have 4 topics I'll talk to you about briefly in my remaining minutes here. 2 topics pertain to the fact that we actually don't know much about how IVIG works. But in exploring how it works, we've developed 2 modalities. One is called hypersialylated IVIG, which I'll talk to you about. And one is to recognize that the Fc portion of IVIG is very active, and you can play with it in a molecular fashion to make new drugs. Then I'll mention 2 standard kinase inhibitors. One is Syk kinase, and one is Bruton kinase. Both of these have brand new data that is just weeks old that I'll present to you in terms of the efficacy of these molecules in an ITP. So for For the next 5 or so minutes, we'll talk about these molecules, and let's start with IVIG. This is IgG here. Here's the antigen binding regions here. Here's the FC portion I mentioned before. It turns out that naturally in all of us, only about 5% of our IVIG is sialylated, has these sialic acids on the FC portion of the molecule. And this actually makes IgG different. This IgG molecule differs from this IgG molecule in how it works. And it turns out that this sialylated molecule has an interesting effect upon macrophages. I described to you a minute ago that antigen-antibody complexes, in this case platelets, bind to Fc gamma R3. If you give them sialylated IVIG in a test tube or in an animal, what happens is you upregulate an inhibitory Fc receptor called Fc gamma R2b, which prevents internalization. So one of the effects of IVIG relates to the fact that a small component of it, which is sialylated, upregulates this inhibitory receptor. And what you can do is you can take IVIG, and this is a cartoon I made myself, so that's why it looks a bit blurry, but you can take IVIG in a big bag and put it through a chemical process and add to it sialic acids. And when you do that, you make tetrasialylated IgG, and this stuff is about 10 times more potent than regular IVIG. How do we know that? This is a typical model in animals that, like Harrington did, you take an animal, inject an anti-platelet antibody, and the platelet count drops. If you give the animal a regular IVIG in the red or sialylated IVIG in the blue, you require 1/10 as much sialylated IVIG to raise the platelet count as you do regular IVIG. And this is a much more potent component of IVIG, and this is being studied in a wide variety of clinical disorders. Other important point, going to the second aspect of IVIG's function, we knew back in 1993 that if you took IVIG and cut off the antibody combining regions and just infuse the Fc portion of the molecule, you could raise the platelet count nicely in most kids. This data remained cryptic until 2 or 3 years ago, when a lot of groups have explored at the Fc portion. And what you can do is you can purify the Fc, and then you can make recombinant dimers or funny trimers here, or pentamers. And it turns out this trimeric substance right here totally turns off macrophages. It binds to the Fc receptor on macrophages, but it makes it not work. And this molecule is now entering clinical trials. In animal studies shown here, again, the animal model, you give an animal anti-platelet antibody, the antibody drops, the platelet count drops to low levels, IVIG works here, but this molecule at its highest dose just about normalizes the platelet count. So this is 40 times more potent than IVIG, giving us another anti-macrophage molecule to use in ITP. Again, clinical studies just starting. Well, I left the story off. I've talked to you about these two molecules. Let's end our discussion by talking about Syk kinase inhibitors and Bruton kinase inhibitors. One of the Syk kinase inhibitors is fostamatinib. This inhibits Syk down here. I'll talk about rilzabrutinib that inhibits BTK up here, but there's a brand new Syk inhibitor called sovleplenib the data was presented at EHA a month ago. I'll show you that data in a second. As a way of introduction to Syk inhibitors, this is fostamatinib, not a great drug. It works about 18% of ITP patients have a response versus 2% on placebo. This is an FDA-approved drug in many countries. It's not as effective as one would like. And the reason why it's not as effective is it's got a lot of side effects. Now, if you look at what is called a kinase map, this tells you what the molecule does. Fostamatinib inhibits Syk, but it inhibits dozens of other kinases, giving it a lot of off-target effects. A newer Syk kinase inhibitor called sovleplenib inhibits Syk and to a much less extent inhibits a few other kinases. And this molecule has been widely studied, and the phase 3 data was presented in Madrid less than a month ago. And this study is nicely shown here. If you look at what's called durable response, which is a platelet count over 50,000, on 4 of the 6 last visits. On active therapy, response was 48% with active drug versus 0% on placebo. And this is shown here. This is the, again, rapid rise in platelet count, almost over 100,000. That was well maintained. These are incredible data for ITP in terms of rapid response by turning off the macrophage and raising the platelet count. Side effects were rather modest, if any. And more importantly, these patients did not require any rescue therapy. They required less rescue therapy for ITP. You could reduce their corticosteroids in 27% of patients, and their bleeding became a lot less. So there are a lot of variables here, but the most important variable is the next slide. And that is the quality of life improved. Physical functioning, energy, and general health improved, not hugely, but they improved modestly in patients given this drug, suggesting that one of the major physical endpoints of ITP got resolved. Finally, we're going to talk about the BTK inhibitors, and we know about BTK inhibitors a lot because ibrutinib is a nice molecule. Many of you have used it. These are all CLL patients who have concurrent ITP or hemolysis. These black bars are events of hemolysis or ITP. You start the patients on ibrutinib, and most of the hemolysis and ITP disappears. 19 of 22 patients had resolution of their ITP or warm antibody hemolysis. And this has led us to develop a new drug, which is a drug called rilzabrutinib, which is a BTK inhibitor that has a couple of interesting qualities to it. It binds BTK quite nicely. It has a therapeutic effect that lasts for 24 hours given orally. It has a very short dwell time in the circulation, meaning very few side effects. But whereas ibrutinib decreases platelet aggregation, rilzabrutinib does not do that, and it makes it a very attractive molecule to give to patients with ITP. So we published this data in the New England Journal of Medicine 2 years ago. 40% of patients who got this drug with ITP had their platelet count rise rapidly and was maintained for 700 days. We've now gone out to 2,000 days. The non-responders are down here. So this drug has worked quite well. We've done other studies, which we presented a week ago or 2 weeks ago at the ISTH meetings. And basically, I just showed you data for part A, but part B was more patients on this drug for a longer period of time. Basically, the data shown here is that we have 41% of patients given this molecule have a platelet count over 50,000, and that platelet count in responders was maintained for about 95% of the subsequent days on the study. And this is the platelet count rise. These are placebo. These are the non-responders. These are the responders in the 2 different parts of our study. The platelet counts remained elevated for a long time, and the quality of life also improved. More importantly, the time to response was 12 days, which gives you a very rapid response time for most patients. I'm going to finish with one last slide and describe one of the mechanisms of ITP that is of question. And I'm going to say this data needs to be taken with a grain of salt. We know that platelets are coated with sialic acids. If you give a platelet neuraminidase that comes either from injecting neuraminidase or the neuraminidase from a sepsis from a bacterial infection, we cleave off the sialic acids, and these desilated platelets head to our spleen and bind to Kupffer cells here, and the Kupffer cells destroy them. So this is a mechanism that you commonly see in patients with sepsis causing thrombocytopenia. It has been proposed that in ITP patients, some of the antibodies against the platelets activate a neuraminidase and thereby desilate the platelets. And this has led to the question of whether Tamiflu, which is a neuraminidase inhibitor, works. And this is a study that was published from our colleagues in China a couple of years ago. They gave patients dexamethasone or Tamiflu versus dexamethasone, and they show that there is a modest increase in response rate at day 14 by adding this molecule Tamiflu to patients. I'm going to simply say right now that our group has studied Tamiflu for years. Tamiflu has no effect upon human neuraminidase, so although this is the data, I'm a little suspect of it. Further studies need to be done to look at this. So in conclusion then, I will simply say that ITP has a complex pathophysiology, and understanding it helps guide therapy and particularly new treatments. It is a disorder of reduced platelet production. Corticosteroids and TPRA increase platelet production, and there's a new TPRA called heterothrombopeg, which, if it's cheaper, might be a better drug or easier drug to use. From a new development point of view, the major focus has been to regard ITP as a disorder of increased platelet destruction, and we can reduce antiplatelet antibody by neonatal FC inhibitor inhibition, by IgG proteases, maybe by BAFF receptor inhibition. Anti-CD38 looks incredibly promising with daratumumab and the TAC molecule being associated with this. We can try to inhibit complement. I think these studies are modest at best. Finally, we can inhibit phagocytosis with modified IgG, either hypersialylated or recombinant FC multimers, or we can inhibit SYK with the new molecule sovleplenib, or possibly inhibit BTK with the newer molecule rilzabrutinib. Right now, we don't yet have a cure for ITP, but all of these are very effective potential therapies for ITP that will be appearing, I think, clinically in the next 2 to 3 years for this disease. What we don't have yet is this, which is a blood purifier. This is available in Canada in 1865, and this is a bottle of it on a shelf in a museum up in Canada someplace, which I visited many years ago. But we don't have a blood purifier yet. Maybe the IVIG cleaving enzymes may do that. On that, I'll stop, and I'd be delighted to take questions from you. Thank you.
Thank you so much, Dr. Kutter. That was super. Enjoyed such a lot of new information, so much work, and you put all that together in 45 minutes to us. Grateful to you. Absolutely grateful to you. So we have questions from our colleagues, but I have one question for you. With all these things around, do you think the steroids could be got rid of totally in the treatment?
Yeah, I think right now there are two things I'd say. One is that steroids should be minimized currently. So I think there are patients we should minimize them certainly under 2 months. But I do think many of these therapies, as we explore them as upfront therapies, work so fast, they probably work faster than steroids do. So, for example, the data I showed you with the anti-CD38 molecules, they work in 7 days. They may work in 3 days, but we didn't check them. So I think the bottom line is that I'm very enthusiastic that steroids will disappear. The problem is that steroids are cheap. These molecules are bloody expensive. And I think that's the real negative about all the new therapies. And that's pretty true in many countries.
Thank you. Dr. Rajat, your question.
Yes, Dr. Kutter, that was fantastic. I mean, so it looks like ITP is a simple disease, but it looks like we know less and less about it. Can I ask you?
That's exactly right. I agree completely with that. Okay. Yeah.
Can I ask you a practical question? So I have a kid who is 8-year-old, currently in my hospital, was treated outside for ITP, single-digit platelets, some mucosal bleed, but he was treated quite aggressively with IVIG steroids and a dose of romiflostim, and he ends up in my clinic with a extensive CSVT, cranial sinus thrombosis, with platelet count of single digits again. So of course, pathophysiological basis, do I need to look for other thrombogenic diseases, or I can just take it's ITP, which is treated aggressively, and maybe romiflostim? That was one question. And second question is, of course, I'm anticoagulating this kid, but how, by pathophysiology, which drug will be, I'll be more comfortable in at least having a reasonably safe platelet count of 50 during the anticoagulation of 3 months? Thank you.
Yeah. So I think my response is several to that question. This is a complex question that we could talk about for 2 hours. So I'm going to be as good as I can and short as I can. ITP is a thrombotic disorder in itself. Of the drugs that we know, only IVIG is prothrombotic as a drug. So if you look at IVIG as a therapy for anything, it has an increased rate of thrombosis directly related to drug. To date, there are several meta-analyses published that show there's no increased risk, statistically speaking, of thrombosis with the TPRAs. I think that at some stage we look at thousands and thousands of patients, we may find some small statistically increased risk. But to date, I wouldn't blame the drugs. I'd blame the disease and possibly IVIG. In terms of what's this, and so I would use, in a kid like this, I'd try to maintain the platelet count above 20,000 to allow adequate anticoagulation. I don't think you need a higher platelet count for anticoagulation. The reason why is in ITP patients, as you well know, the platelets are usually big, they're usually hyperfunctional, and these patients rarely bleed at platelet counts of 10,000. So I think right now I'd have a lesser goal of platelets for anticoagulation. But I think it's probably the IVIG complicating the ITP. But again, it could just be the ITP.
Okay, sorry. Any agent of choice to have a sustained platelet count?
Yeah, I think right now, whatever works, whatever agent works, I'd use. If a patient did well on L-trombopeg, I'd use L-trombopeg. If it did well on Remiplastim, I'd use Remiplastim. My goal would be to modestly increase this kid's platelet counts to 20 to 50,000 to allow him just to lead a better life.
Yeah, okay. Thank you so much. Thank you.
You're welcome.
Dr. Narendra.
Thank you, sir, for keeping this nice topic, which is actually interesting for many of the pediatricians and physicians also. This was an enlightening talk. Actually, a lot of new things I learned. But one of the old treatment which we still use, I wanted to know any experience from your side, that is Dapsone. Actually, we use Dapsone in India as a for chronic ITP. We use as a first line, and because of cheap drug and very well tolerated in if G6PD deficiency we actually exclude before only. So, what is your experience and what is the mechanism of action involved in the Dapsone? It is considered as immunomodulatory medicine, but what is your take on this?
Yeah, I appreciate this question because I like Dapsone. I've used Dapsone for 50 years. So it was one of my drugs of choice 20 years ago before the new agents came out. It's cheap. It probably works about 40% of the time. The database to support its use, I've encouraged many of you and your colleagues to publish at some stage because their database to support its use is rather thin. There is a publication under review right now from a journal that I can't comment upon that looks at 60 cases of Dapsone from I believe it's from Canada, that shows a response rate of 40% with minimal side effects. So I would first of all encourage you guys to publish something given the ubiquity with which that drug is used in India. So to answer your question, I like the drug. It works maybe about a third of the time, maybe 40% of the time. In patients where it doesn't work well, it oftentimes gets your counts 10,000 more, which gives me a little bit of a leg up. So I use this drug a lot in my patients who are marginal patients. How it works, I think, is still a mystery. I still think that all the Western patients I treat with it always drop their hemoglobin by a half gram. So I think that the major mechanism still is the fact that it's a strong oxidant stress, and in patients who don't have G6PD deficiency, it's probably hemolyzing some red cells that keep the macrophages occupied.
Easy.
They don't eat the platelets. But the discussion about it being immunomodulatory, you got to go back 60 years to actually find data, and that data doesn't exist. So I do think right now, I'll be honest with you, as a group of hematologists who use this drug much more than is used in the West, I would encourage you to think about just putting your data set together just to ask what its response rate is, how long does it last, what's the right dose, and that would be a huge benefit to all of us. So the answer is, I don't know how it works. I guarantee it hemolyzes red cells in normal patients as well.
Yeah. Thank you.
That's my best guess.
Thank you. Dr. Amita?
Dr. Cuter, thank you for such a fascinating presentation. I mean, some of it was like science fiction for us. And I have a very basic question on just Romiplastim in day-to-day practice. What is the starting dose that you use? We know what the literature says. If there's a dramatic first dose response, then what do you do for subsequent doses? And once you've got, if you over a period of time, you have a tremendous response, then do you just stop, or do you do some kind of tapering like we do for a thrombo bag? Yeah.
Yeah. Well, again, that's a good question, and I appreciate it. So first of all, my usual starting dose in adults is 3 micrograms per kilogram if someone is reasonably stable, like their platelet count's over 10,000. If someone's bleeding to death, I'll start the maximum dose of 10 micrograms per kilogram and work my way down. Number 2, almost all TPRAs, if they work, give you a rather rapid first dose effect, as we've published for years. And if you keep them on the same dose, within 2 weeks, it drops. So if there's a rapid rise in the first 2 weeks, I don't do anything. I keep them on the same dose. If they still have a high platelet count, I'll cut the dose by 50% each week to see what's going on. What I don't do, and I think we've talked about this before, is I don't just stop the drug, because if you do, a week later, the platelet count may be back down to 0. So I think right now, to answer your question, there are 3 answers to your question. One, with the first dose effect, just wait it out and see what happens by the time you're doing third dose, think about changing a dose if it's high. Number 2, our goals with the TPRA is to maintain a platelet count between, say, 50 and 150,000, which sometimes is hard to do, but that's my usual target. Thirdly, if someone has a consistently high platelet count over that, I will gradually wean them by anywhere from a third to a half every couple of weeks until they're either off the medication or their platelet counts drop below 50,000.
Thank you. That's very useful. Thank you.
Thank you, Dr. Amit. I'll take one question from the audience, and this is regarding the TPO-RA during pregnancy. More and more being used. So what's the safety like?
Yeah, there are 2 publications on this, and there's the 3rd publication that we publish in Blood on how I treat pregnant patients. There was the first author is Fogarty, the second author is me, and I think Dr. Fogarty came and visited you guys about 8 or 9 years ago. But anyhow, so I will simply say that if you're going to use the TPRA in pregnancy, I would use Romipilstim, not the other 2 agents, because of their potential off-target effects or their effects on iron. Number 2, if you're using Romipilstim, I think that we usually use it in the 3rd trimester. If we need to use it at all, we'd use it primarily in the 3rd trimester to prepare a patient for delivery. But we have patients who have very bad low platelet counts and bleeding during the entire pregnancy, and we've used the agent during that time. The data to support its use has been rather encouraging, that there's been no significant side effects either on mother or baby. But I would still say that we don't know the full truth about this, and I would simply say that we're still learning. In a bad patient with ITP, and maybe be the only option you got, use it. But I would certainly only use Romipilstim. It's much more targeted in terms of its effect.
Thank you. Dr. Shrikant.
Sir, thank you for such a wonderful talk. Each class session of ITP, we get to know new things each time. My question is, how early can we start TPO analogs in a child, especially who has not responded to steroids, IVIG? What can be the early time frame where we can consider TPO analogs? And the second question would be, in pediatric ITP, where we cannot use other medications upfront, we don't have approval. So what would be the drug which is, in your experience, which immunosuppressant would be preferred compared, like MMF or cyclosporin or vincristine?
Well, I'm going to say that the youngest patient I've ever taken care of is 18 years old, so I'm not a pediatrician, but I hang around with lots of pediatricians. I will simply say right now that if you talk to someone like Cindy Noonert, who I lecture with a lot and is a good friend, they'll start the TPRAs very early. I mean, there's no, if someone doesn't respond to steroids and they still have a low platelet count, that is usually after IVIG and prednisone. Actually, maybe take it back. The current therapy in pediatrics in the United States is IVIG instead of prednisone. But if they don't respond to IVIG, prednisone will be given. If they then fail, they'll immediately switch in a short period of time to TPRA. So I think right now the TPRAs, I think, are safe and highly effective in pediatric ITP. Your other question about whether you're limited in terms of what immunosuppressant to use, again, I can't comment upon that in kids. I will simply say that in adults, we commonly use, in lieu of prednisone as our immunosuppressant, we use mycophenolate. That's my favorite immunosuppressant. But again, I can't help you that much with a pediatric patient. I'm sorry.
No, thank you, sir.
Thank you, Dr. Shrikant. Another question from the audience. is regarding rituximab in pregnancy.
Yeah, again, we have given rituximab in pregnancy for years for women with lymphoma with no negative consequences. I personally don't see any huge downside to it to mother or baby, but I'd also say to you that it may take 2 months for it to work. So oftentimes you've got to wait a long time for its effect, which is why we don't commonly use it. We would pretty much prefer to use a TPRA if necessary, or just live with corticosteroids, IVIG, and respect that we need a platelet count no higher than 15,000 to maintain a mother throughout a pregnancy. So I would encourage you to read our review article in Blood, How I Treat. We talk about rituximab, but I think it's a agent which rarely has use in active pregnancy. I can envisage a couple situations where it might be used, but it's rarely used. My current use of rituximab in pregnancy is mostly in women who want to get pregnant, who've had ITP before or have ITP now, and to give them a 4-week course of it, maybe 6 months before they get pregnant, to try to mitigate what might happen during their subsequent pregnancy. So I use it usually before pregnancy.
Thank you. Dr. Vignesh.
Yeah, thank you, Dr. Kuter, for a wonderful talk. So I'm a pediatric immunologist. So we have seen many patients, especially male children with chronic thrombocytopenia, managed as ITP, but finally turned out to have X-linked thrombocytopenia. And some patients with chronic ITP have an underlying antibody deficiency or a common variable immunodeficiency as well. The therapeutics are a little different in those group of patients who have underlying antibody deficiency or a viscous outrage. So in your practice, when would you consider a monogenic inborn error of immunity in any patient with chronic thrombocytopenia?
Yeah, so you raise a great question. Again, as I said, the pediatricians have a harder job than the adult hematologists do, because you have a lot of things that may present at birth that are thought to be ITP and aren't. As an adult hematologist, I would say that maybe 1 or 2% of the patients who come to me with a low platelet count have some other disorder that's genetic, and we have a screening. We have a screen that we send that if someone comes to you with a history of ITP all their life, I will certainly send a genetic screen to look for mutations that cause inherited thrombocytopenia. I think there are currently 62 different genes in that panel that we assess for. Those are easy to take care of. What is sometimes the case is I'm sent patients with lots of ITP, and in those ITP patients, I will always send a serum protein electrophoresis to see if they're hypogammaglobulinemic. It's amazing how many adults have CVID and don't have a heck of a lot of infectious complications, but they do have a lot of immune complications. So the two situations you've mentioned to me, kids, are much less common in adults, but in the adult with a history of long-standing ITP, we always worry about it. And in the adult, I will always send my usual immune panel in adult is to send a serum protein electrophoresis, anti-thyroid antibodies, anti-nuclear antibodies. I would check for a anti-phospholipid antibodies just to get a gestalt as to what their immune status looks like. But the CVID patients are obviously treated totally different than those with typical ITP.
Thank you.
But you pediatricians got a harder job than I got.
Thank you. Dr. Jagdish.
Thank you, Dr. Kuter, for that wonderful talk. I am a pediatrician, but my question is not related primarily to pediatric age group. My question is related to when, say, these molecules become available to us, how one decides which type of therapy to use, whether to hit the underproduction or whether to use a drug which is, taking care of hyperdestruction. Are there any tests, or are there tests in pipeline which would at the bedside help us in deciding which form of therapy to be used? After the first line therapy, we need to, decide which therapy we have to go to.
Well, so far, the data I didn't have time to present to you, in all the studies with new molecules that have clinical data for them, we've tried to assess what patient variables predicted a response or lack thereof. So far, the only data we know that predicts response to certain drugs are if your thrombopoietin level is very high, you don't respond well to a TPRA. That's a fact. And that's something we check in everybody getting a TPRA. With regard to all the other molecules I mentioned to you, so far we haven't identified a clinical variable which predicts whether someone's going to respond or not. And that's the problem, because these drugs are expensive. So at that point, if I had to pick a new molecule, I would ask if costs were nothing, and that's always a difficult problem, but if costs were not a consideration, I would find the molecule that probably has the greatest chance to give me the longest, what's called treatment-free remission. And so if we have data that says treating for 4 months with a anti-CD38 molecule gives you 4 years of treatment-free remission, meaning a better response than rituximab, then I would choose that molecule. If we don't have any data about long-term remissions that are treatment-free, I would probably pick an oral molecule, and the TPRAs orally are very good molecules. They're hard to beat. So I still think an oral molecule over a chronic infusion is going to win out. But if I said to a patient, 4 months of a therapy and it's all done and you're cured, that's the goal. But we haven't got there yet. So I don't have an answer to your question. It's obviously the question, and then it comes to the cost of all these things, which is just ridiculous. I mean, it's obscene.
Thank you, Dr. Jagdish. One more question from the audience. Have you ever used Eltrombopag and Romiplastim together? As in India, we have generics and the cost is not an issue.
Well, we have generics as well, and the cost is an issue, but that's a different story. But I will simply say right now, the answer is no. I haven't done both together. There is an argument to use Romiplastim and Eltrombopag together because they act on the receptor differently. I don't think that a 10% greater activation receptor is going to make a huge difference in ITP. If I had to add a second drug to an ITP patient, it's going to be an immunosuppressive drug, or in some patients, and this has been published by our colleagues in Europe recently, adding fostamatinib as a different mechanism of inhibiting macrophages. So I think around if I had to have 2 drugs, if I had to use 2 expensive drugs, I would use a TPRA of one type and then add to it either an immunosuppressive drug or a Syk kinase inhibitor like fostamatinib. Fortunately, we have such a high response rate with the TPRAs of almost 90% with platelet counts going above 30,000 that fortunately these are common discussions, but the disease situation is rather uncommon.
Thank you. Dr. Kritika.
Hello, Dr. David. I think we all are leaving this conversation with a much more greater depth of understanding of ITP than how we entered the lecture. So thank you for that. While I was reading the literature about it, I'm seeing a lot of exciting and interesting studies coming up where people have used decitabine and even atorvastatin in cases of ITP. So what is your view about these 2 drugs? Do you have any experience using them? Have you had any success?
Well, I've not used them as drugs for ITP, but they're so commonly used that it's hard to find a patient with ITP who's not already taking those medications. So to be honest with you, I don't have any experience, and I don't know of any real study that proves efficacy. I would also say that it's hard to imagine a mechanism that would explain why they might work. And I'm not here to say they don't work, but I'm just saying I don't have a mechanism in mind.
Yeah, that's pretty interesting to know that how it would work.
Yeah, I agree. I'm going to say that I've given you a model of ITP, which I think is still very primitive. And when we talk about this again in 2 years, we're going to talk more about NK cells and cellular immunity than we are going to talk about IgG. We are colored by Harrington's experiment where antibodies made the platelet count drop. We're colored by the fact that in animal models, we add antibodies to the animals and make their platelet count drop. But ITP is a much more complicated disorder than just an antibody that you got to make disappear. And I think that's the real challenge. So, if someone said to me, atorvastatin works in ITP, I would say that's surprising. But I think about a very novel molecule and how a very elegant model how it might be working. So yeah.
Absolutely. Thank you.
There's a lot to be learned here. It's a much more complicated disorder than we think.
Dr. Kuta, Dr. Narendra Chaudhary has put up your article about thrombopoietin level predicting the response to TPOs.
Yeah, it's again, it's if you can get the test done in your country, it's a rather cheap assay, just how it's done, but it does save you using an expensive drug if you don't need it, won't respond to it.
Thank you. Dr. Siddharth.
Thank you, Dr. Cuter, for this amazing talk. So my doubt is a very basic doubt about the diagnosis of ITP. We are always taught to have a very minimalistic approach to diagnosis, sending only a complete blood count test smear and doing a thorough examination. On the other hand, we also say ITP is a diagnosis of exclusion, and it is associated with complications like thrombosis, and we tend to postpone testing for APLA, ANA, etc. for a much later point of time. So what is your comment? Are we oversimplifying the diagnostic approach? Should we be more aggressive in investigation?
Well, I think that, ITP clinically is an easy diagnosis to make. It's much more complicated than we think it is, as we just talked about. Our standard approach to ITP patients is to, platelet counts 10,000, platelets are big on the microscope, there's no leukemia, other blood counts are normal. I will still send in those patients, and this is done because I do research on this topic. I send an anti-platelet antibody just for my own interest. I will send a thrombopoietin level because those should invariably be low in patient ITP. I'll send anti-phospholipid antibodies, a lupus anticoagulant, anti-cardiolipin antibodies, a serum protein electrophoresis, and anti-thyroid antibodies, just to get a general view of that patient's immune status. Those tests are not recommended by any current guidelines. The current guidelines just say a diagnosis is a diagnosis exclusion, and that it looks at, and that's the blood smear and the CBC. I think that's a minimalist approach to ITP, but there's nothing wrong with it. It served us well for most patients. So thanks. I think that my own personal view is we should be testing more for other secondary causes of ITP, and that may not change what we do any, but it is what we do. It was what I do.
Thank you, Dr. Siddharth. Another question from audience is, so is there any place left for splenectomy in treatment of chronic refractory ITP?
I'm going to say, yeah, globally there is, because globally many of these therapies aren't available. And I'll just be blunt about that. If you can't afford the therapy, splenectomy works. So let's not ignore it. There are side effects of splenectomy we all know, but if there are no other options to the splenectomy, then there's nothing ethically or medically wrong with doing it. I think right now, as I said, I have only done 2 splenectomies in the last 30 years, and they're both in Air Force pilots who need to get back in the Air Force as fast as they can, and they couldn't go up an airplane on a medication. But the question, is there a role? It depends upon the clinical situation, the economic situation of any particular patient or the country. So if you said to me, is it wrong to take out someone's spleen? I'm living in India and I can't get the medic. Yeah, of course, take the spleen out. That it works. Let's not ignore that. It's an effective therapy.
Thank you.
But by using splenectomy, you create a separate disease, which is asplenia, which has its own risks, and we all know what happens there.
Yes, Dr. Kapil.
Thank you, Dr. David, for a very wonderful and fascinating talk. I have 2 questions for you. One is, how long can one give TP agonist continuously? And another is, in chronic ITP, what would you prefer? Would you like to put patient on long-term TP agonist, or you would like to give rituximab first so that patient can be off the drugs if there is good response?
Grant, I've got, since I developed these molecules, I've got a patient who's been on a TPRA since 2004. So he's been on it for 20 years and he still needs it. Every time we try to take him off of it, he crashes. So he's done well, and he's done so well that he refuses to even attempt other therapies. Your question about rituximab is an interesting one. And again, it goes back to some of the socioeconomic differences in different countries. And I'll be honest with you, if one is resource limited, since Rituxan is pretty cheap globally, it may be smarter to have an algorithm where you use rituximab first, give that patient a chance to have a remission, which, albeit small, remissions are 57% with rituximab at 6 months, 39% at 1 year, and 21% at 5 years. there's still that 21% where, you don't need any therapy. So it may be a decent algorithm in resource limitations. Many patients, I hate to say this, but many US patients don't want to take a chemotherapy drug, which I think is all nonsense, but they would rather take a TPRA pill than to get rituximab. I personally think that long-term remission rates at 5 years are the same off therapy of a TPRA and with rituximab. So if you did a study where all people on TPRAs came off at year 3 and patients were monitored after rituximab, everyone measured to year 5, you'd probably find a 21% remission rate in both groups, meaning they don't require any therapy. There are some patients who want to have a brief course of therapy, which is why I'm attracted to the new anti-CD38 molecules, because they are weekly for 8 weeks. And if you can cure the disease or give them a remission now for 3 or 4 years, that will change my view. So let me just reverse this for a second, I may, and say, if the anti-CD38 molecules are better than Rituxan, and instead of having a 21% remission rate at 5 years, you've got a 40% remission at 5 years, I think the whole paradigm would be to switch to a anti-CD38 molecule and not give people 5 years of an oral medication.
Thank you.
Dr. Sunil?
So, thank you, Dr. David. It was very wonderful discussion. So I just want to know the combination of TPO-RA along with low dose steroids or maybe MMF, and which choice of TPRA may be combined with this immunosuppression, and which will have a better efficacy. I have read some of the adult trial which showed a very good response, particularly DEXA and MMF. So what is your experience regarding this combination of TPRA and low dose steroids or immunosuppressions?
Yeah, we've published this on and off for a couple decades, for 15 years now. So we will always tell you that adding a low dose prednisone, like 5 or 10 milligrams, to a TPRA person who doesn't have a good response will oftentimes convert that person into a responder. In more recent years, we have all done the same thing with mycophenolate. So our current approach is, if someone is on a TPRA and the platelet count goes from 6,000 to 20,000, and we may want to get a higher platelet count, we'll add 5 milligrams of prednisone, or add to them Cellcept, mycophenolate. So I think right now I commonly add low doses of immunosuppressive agents to those who don't have the best response to a TPRA before switching to other agents or adding fostamatinib. So it's a good strategy. It works really well in about half the patients who don't quite make it to where you want them to be. Now, remember, the flip side also occurs. If people are on prednisone or steroids, and you then start decreasing their steroids, the response to the TPRA, which you think is initially very good, may become less good. So it's something, it works both ways.
Okay, thank you for the comment, because there is no guidelines in the literature as such regarding, particular in pediatrics.
Yeah, well, again, I will simply say that we're writing it with the new guidelines we're writing right now will include that.
Okay, thanks a lot.
The question from audience: is your algorithm for Evans syndrome any different?
Yes, it's totally different, and I thank you. We've just finished analyzing a 700 patient Evans syndrome at our hospital, just to know what it's like. I'm fascinated by Evans syndrome. I'm going to talk about adult Evans syndrome, not pediatric Evans syndrome, but an adult with Evans syndrome, our common approach is use rituximab first. They obviously all get steroids to get their counts up higher. They usually respond quite nicely. We'll then use rituximab, and that gives us a very good response for many patients. What you do after rituximab is often difficult, because some Evans syndrome patients become, since the disease may not be synchronous, they may have asynchronous disease where they have warm antibody hemolysis 1 year and ITP the next year. You sometimes are playing a game between corticosteroids and TPRAs if they have ITP. So the initial therapy, I think, for everybody ought to be corticosteroids followed by Rituxan.
Thank you. Dr. Anand Prakash.
Thank you, Dr. Kuta. Very enlightening talk. My question, you already spoke on markers for response to thrombopoietin agonists, but sometimes we face that challenge in families who've taken it for some time and want to decrease the dose and stop. So are there markers to tell us which ones would have a treatment-free remission, just to get us a sense as to which agent we could guide families to take? Thank you.
Yeah, that's a great question. I think right now there are no tests you can order that would help guide you in that regard. The only way to assess that is to do it. And so if someone has a platelet count that's 250,000, I will certainly over the next 2 months gradually decrease their TPRA dose. And then you got to, then you have the challenge, which I'm sure you've had, which is you're on a low dose of a TPRA. The platelet count's now 45,000 or 35,000. What do you do? Well, I oftentimes will discuss with the patient whether it's worth coming off the medication entirely just to see. And I have many patients who are on a low dose of L-Trombopeg, maybe 1 pill or maybe 2 pills a week. Their platelet counts are 35,000. I will say, let's go to 1 pill, and then let's go to 0 pills, and we'll watch you closely, and we'll see what happens. And there are about half those patients I get off therapy, and they live at a platelet count of 18,000, and they do fine. The other half go lower, and I put them back on the L-Trombopeg. So,
okay, so do you feel that's part of the natural history of disease, or do you feel we've actually helped them by giving the TPO?
Yeah, I think the answer, I think we probably, there is sufficient data right now to say that the response to a TPO may somehow mitigate or reduce the activity of the disease. I think how it's doing that's a different discussion, but I think there's sufficient data to say that patients who have responded to TPR for a number of months or years and then come off it have less robust disease than those who have had it before. And the simple statement of fact is many patients with TPRA start the drug at a platelet count of 4,000. They then go to 150,000. You just keep them on it for a year, and then you start tapering it, and then you can taper them down, and they live at a platelet count of 20,000. And I think that time heals all wounds, and I think that's true in ITP. So my usual response is to give every patient who's had a good response a chance to minimize disease. Now, having said that, what is meant by minimizing disease? I've got a patient right now who has 1 L-Trombopeg every 2 weeks. When she goes to 0 L-Trombopeg, her platelet count drops below an acceptable level, but she lives at 35,000 on 1 pill every 2 weeks, and it's great. I mean, she's happy. It's a very economical way of using that drug.
Okay, sure. Thank you. Very helpful. Thank you.
Thank you. Dr. Rajat?
Dr. Kutar, can I ask you about a quality of life question? I know children, they don't have much bleeding, but actually their quality of life and their parents' quality of life is actually very low when they have a fear of bleeding. So 10 years ago in Singapore, in a meeting, you said if your granddaughter or grandchild, I can't remember, develops ITP, you'd rather use a TPO agonist, not steroid IVIG because of the side effect. Do you still stand with that statement for quality of life maintenance? Would you use a TPO agonist and quite upfront in children?
Yes, I do. And I think that the data supports that. And all my pediatric colleagues from Dr. Bucel to Dr. Nunert would agree. And I believe we put that in the last ASH guidelines in some footnote someplace. I think we like to minimize steroids in kids and think that steroids are probably safer in kids than we think that TPRAs are safer in kids than steroids. Again,
thank you.
Depends upon the clinical situation, but I think that children do incredibly well on low doses of TPRA. There's data coming out now with Avatrombopeg as well that shows it's very effective in pediatric ITP. But again, I think that L-Trombopeg, despite its stupid dietary restrictions, is a great therapy for pediatrics. I think we've discussed that. We discussed that a long time ago. So,
thank you. Question from the audience: prolonged use of TPO, does it lead to clonal evolution like in aplastic anemia?
No. I can elaborate if you want, but we've done bone marrow studies, sequential bone marrow studies on patients who are on these drugs, and there's no histologic or clonal evolution that happens in these patients. And as I said, I've got patients on these drugs for now almost 20 years, and there's no sign of other hematologic disorders occurring. This has been studied a lot in aplastic anemia patients. And it's hard to know whether the clonal evolution in aplastic patients is due to the TPRA or just the disease state. So I think that It's a small concern, but not one that I worry about. The example I'll give you is that using erythropoietin for 30 years in patients has not led to a clonal evolution of some other malignancy in patients on it for renal failure. So I don't have much concern about it.
Do you see hemophagocytosis in the bone marrow of ITP patients?
Rarely. You know, that's much more commonly seen in other autoimmune conditions or in patients with HLH. So I don't think you're not going to see erythrophagocytosis in the marrow. The slide I showed you of platelet phagocytosis in normal marrow is hard to look at under standard histology. You need an electron microscope for that. So I wouldn't worry about erythrophagocytosis.
Right. Like children, adults who have got a disease for more than 1 year, do they get spontaneous remission?
Yes. So again, like all autoimmune diseases, you know, I've got a lady who had ITP for 35 years, never got treated. She walked in one day and her platelet count was normal. I thought it was a mistake. She came back a week later, it was still normal, and 5 years later, it's still normal. So remissions happen. They may not happen robustly, but Ingrid Pappinger published a paper in Hematologica, I believe in 1994, that looked at patients who had ITP and did not get splenectomized, and 80% of patients had some sort of remission with time. And I think that's probably the best thing to think about ITP. It's not always as bad as it is at the beginning, later on in the disease course.
Right. Patients with congenital thrombocytopenia or platelet dysfunction benefit from TPO analogs. So should they be used clinically?
Yeah, so some do and some don't. I mean, there are patients with myosin heavy chain 9 deficiency or thrombocytopenic that have been shown to do quite well with adding a TPRA. There are patients who have MIPL receptor deficiencies who don't. So it depends upon the underlying disease state. Wiskott-Aldrich patients do improve, others don't.
Right. Any role of immature platelet fraction in diagnosing ITP?
No. And again, I say it brusquely because I don't like immature platelet fractions because it's a percentage of total. If you look at the absolute number of immature platelets in ITP patients, is oftentimes reduced. So it comes down to how laboratory data is presented. I would actually think that a IPF fraction in ITP, if the IPF is increased in ITP patients, it pretty much just correlates the fact that their mean platelet volume is increased. It just tells us you got younger platelets present. So I'm not very keen on using it. I think it's a test which is oftentimes reported. I've actually had it taken off our machines at our hospital because it causes too much, it misleads us too much. But if you're going to look at IPF, particularly in clinical studies, insist upon the paper presenting the absolute number of reticulated platelets, because they're usually reduced in ITP patients. The percentage may be high, but the absolute value is still low. So it doesn't give me data. It's not like an absolute reticulocyte count.
How common is ITP in association with Kikuchi's disease?
I have no idea. Sorry.
I think that covers most of the question in the chat box. Is breastfeeding permitted? Mother having ITP, is breastfeeding permitted?
Sure. But again, the only concern we have is if the mother's on a TPRA, whether it gets into breast milk. And we have, in our recent publication, we've actually said that it's such a small quantity that it's not an issue. And by the way, another recent publication show that the megakaryocytes in babies and in the fetus are very unresponsive to TPRA or unresponsive to TPO. So basically, at some stage, we're going to do a real study in pregnant patients, giving everybody a TPRA with the reassurance that it doesn't hurt the baby because the baby's not responsive to that agent. But we haven't quite done that study yet. But as time goes by and I learn more about neonatal megakaryocytes, they are very insensitive to TPO agents.
Right. One more question put up is, if somebody gets a thrombotic episode on TPOs, can you continue the TPOs?
Sure. Yeah, we commonly do and try to keep the platelet count at a level that allows us to give them anticoagulation. It is I think right now in that context of someone having a new blood clot, you got to obviously go back and analyze how bad was the blood clot. Were there other mitigating factors for blood clot like obesity or estrogens? And then you got to go back and ask whether the treatment for the ITP is still necessary. So you got to go back and reassess the situation. But in most patients who still require a TPRA because they have ITP and need anticoagulation, will continue the TPRA because hopefully the anticoagulant is going to prevent any further thrombotic events.
Thank you. Dr. Sunil, you have another question? Or anybody else has a question? Okay, in that case.
No, sir. I think that's okay. Thank you.
And sir, thank you very much. You spared a lot of time. First of all, beautiful talk, lot of information, so much of research work. Our whole thinking about ITP has changed. And then this long question answer session, and you answered all the questions very patiently to the satisfaction of everybody. Grateful to you, sir.
Well, thank you. It's always lovely to see you again, and I hope we have more data for you in the coming years, okay?
Thank you so
Thanks a lot, Dr. David, Dr. Agarwal, sir. Very good discussion.
Thank you, sir.
Nice guys. Nice seeing everybody. Bye-bye.
Bye-bye.
Bye.